so that's something I didn't specifically address. Is it more difficult to put a spinal or an epidural in because of the curvature and different shape of bones and things like that in scoliosis patients? The reality is that there's the spine usually ends up being fairly straight down at the very bottom two levels of the spine, which is where the epidural and spinal usually go in. So in my experience in talking with anesthesiologists and people that do these sorts of things, that's really not a reason to not at least attempt to try to do these things. So what we found with our research is that a lot of obstetricians were saying, oh, because you have scoliosis, we're not even going to think about a spinal or an epidural. I think at the very least, finding an experienced anesthesiologist that's willing to work with you with your preferences, and most likely they're going to be successful at being able to get those types of anesthesia.
Diana, anything to add?
I'm just adding something.
So our resident anesthesiologist is here, so she can give us a comment.
I don't know about all that. I don't think I'm not in your league, certainly. But one of the concerns with an epidural is that the medicine spread evenly throughout the epidural space to be able to give you an adequate anesthetic. And I think that would be one of the concerns. Even if you can place the epidural catheter, the spread of the medicine, if it's not equal. But like you said, try it. If it doesn't work, you can always go into a general anesthetic, especially in obstetric patients.
We certainly have a lot of experience using epidurals post-operatively after scoliosis surgery because we can place the catheter directly by looking at it, and it was popular for a long time. It's maybe less so now, but that flow, at least even in the acute setting, seemed to be pretty reasonable. So
right.
Good point.
Are there any scoliosis patients that are mothers with us today? There we go. And so maybe if you're willing to, would you give us your experience with your pregnancies and deliveries? Were you do you feel like you were treated differently or had different recommendations from your obstetricians or things like that?
No, I just wasn't able to have an epidural. Okay. I had my surgery, the Harrington fusion, back in '84.
Wow.
And yeah, I had two daughters, one sitting next to me. She's a year and a half post-op. And the anesthesiologist said a lawsuit waiting to happen. That's exactly what he said. But I'm sure it's changed dramatically since then.
Well, hopefully that's what we're trying to work on, is to provide evidence and data to educate our anesthesia colleagues and patients and things like that. But also one of the concerns that some anesthesiologists have is that if they're putting a needle near spinal implants, will they spread infection and bacteria that can attach to the implants? But I think that's, in general, they're going to be putting it below where your implants are. So that's something hopefully we can educate our colleagues about.
One more quick question? Oh, maybe two. Go ahead.
I'm an OB nurse, and I see this all the time. I see people come in with scoliosis.
Yeah. And
their doctors, their OBs are like, well, you can go through the labor with no epidural, or you can go under general and have a C-section. But they won't touch
the choice.
That's their choice. And that's why I was asking the question, because it's more the anesthesiologist. They won't touch them at all. They said the same thing for a lawsuit.
All right, well, let's have another crack at that.
It's not really bad coming down on the anesthesiologist, but that is.
One of the other options for labor and delivery is a one-shot spinal narcotics, which will give, you can't redose it. I don't know if I'm getting too technical. The difference between an epidural and spinal is where the medicine is in near with respect to the nerves. And if you just put one dose of narcotics in the spinal fluid, then you have X amount of pain relief, but you can't redose it like you can redose an epidural. So that's the other option.
Well, it sounds like we got a little work on our end, and Pat, you suggested it to sort of educate our medical colleagues on that side. You got another comment?
Yes. Not about pregnancy, though.
About anesthesia? Go ahead, please.
How do you manage or monitor growth, and is there any stunting after the rods are put in and after surgery?
Give them an estimate for how much growth is lost per level per year.
So I will quote a number that might be made up, but we're going to go with that one. It's 0.7 millimeters per level per year was kind of the number that I've been quoting, and I've been quoting for a while. That's so if you do like a 10 level fusion and you have 1 year of growth left, that's about 7 millimeters of growth that you've lost in the axial height. And that's kind of the number that I've gone by. But effectively, you remember, if you have a curved spine and you're straightening it, they're gaining back height there as well. And so it's usually, you end up growing a fair amount. Now, what you don't want to do is you don't want to do something too early where it affects lung volumes and lung development. And usually that's the age that we kind of look at that as the age of 8. And so if you're beyond that, that's really not as much of a concern, but those are the kind of the numbers that we go by.
Good. Anything else? Go ahead. Hey.
The evidence about going back to pregnancy, about pregnancy and scoliosis sounds. Thank you. The evidence about pregnancy and scoliosis at this point sounds kind of like anecdotal. How do you foresee taking this issue and sort of like making it into real data that doctors and like anesthesiologists mainly can use in the future for people like us who will be having kids in the next 10, 15 years?
Yeah, that's a great question. We're really early in gathering really good data on this. But as Dr. Clements showed, the harm study group started 20 years ago with people just really trying to look critically at the outcomes that their patients were having. And that's what we're starting to do now with those patients that are now maybe 8 to 10, 15 years out from having scoliosis surgery. We're trying to capture those 3,000 patients that we have in our database and the 80% of them that are women that are going on to, many of them have children, and we want to capture that data going forward. So we're at the early stages of that. That's something that maybe strikes a chord with people out there that would be a reason for you to support financially setting scoliosis straight as well. But yes, we are.
Find your friends who've had babies and had scoliosis and get them to fill out Pat's questionnaire.
Yeah.
I mean, we start most of this type of research in a retrospective way. We look back, gather, and see what we can learn from that retrospective look back, and then we design a prospective study going forward to really get, the stronger evidence that we can really make recommendations from. But we've got to do this retrospective work first.
Thanks for doing it.
Great. Any other questions for this game? Very good. Well, thank you all.